Ready to start the journey to pass the test?
Yes.
So welcome to session 5. Remember to join me in this mission. Our goal is to provide free NCLEX RN application review to 100 nurses. Now for the review, my foundation is usually giving it, while for the application, we're sourcing out from sponsors. And to help us achieve this, just watch and finish the ads in our video. So just watch our videos at Gapus Mentors. You could actually rewatch the content of the QuickFix sessions, including QuickFix session 1 in Gapus Mentors, okay? So our YouTube channel, once again, Gapus Mentors. So if you have some questions or requests, send me some message through mentor.raygapus@gmail.com. So let's begin with a positive mindset. People rarely succeed unless they have fun in what they are doing. My question is, are you having fun, colleagues?
Yes.
Are you having fun? May nakaganyan. Okay.
Absolutely, yes.
This is the way to have fun. This is the way. For example, everybody, let's imagine ourselves in front of the computer. We're about to take our NCLEX, and all of a sudden, something weird, a question that covered a concept that we don't know, out of this world, suddenly pops out of our screen. Okay? The unsuccessful test taker would say, oh my God, this is difficult. How can I do this? How will I answer? Then they blame themselves. It's because I didn't study. It's because I didn't read. It's because I didn't listen. That's not the way to do it. Dale Carnegie said, people rarely succeed unless they have fun in what they are doing. So if something that you don't know pops out of your computer screen, have fun. How do you do it? Say to yourself, I don't know the answer. Why is that so? There's a physiologic basis for that. According to cognitive theorists, laughing increases the brain oxygen levels, such that when the oxygen levels in the brain is increased, you become more alert. Therefore, if you don't know the answer to a question, don't give up, but try to increase the oxygen in your mind. So you say, I don't know it. So after laughing and you still don't know the answer, laugh harder, laugh louder, laugh some more and say, I don't know the answer. So if you see somebody who's taking the NCLEX and the person is laughing and laughing and laughing in front of the computer, it simply means that person doesn't know the answer. And you're not alone, okay? Is that comforting enough? Okay, let's move on. So how to have fun? Laugh at yourself. Okay, so here's a question. A client seeks consult for treatment of depression. Look, it began with the concept of depression. On admission to the emergency department, he is drooling excessively and exhibits clumsiness as described by his caregiver. Here are two things that you have to focus on: drooling, clumsiness. What should come to mind? Depression, drooling, clumsiness. Okay. Then, upon further assessment, the client was also found to have mild cognitive impairment. Which of the following manifestations should the nurse address first? So, if the question is just asking you, which will you address first, you don't have to come up with a diagnosis. But if we're going to come up with one, look, there's drooling, there's clumsiness. We could consider Parkinson's disease. However, in patients with Parkinson's, they usually have minimal or no cognitive impairment. Cognitive impairment occurs in patients with Huntington's disease. So chances are this could be Huntington's disease, but that's not what the question is all about. The question is asking you, which manifestation should the nurse address first? Are we going to address depression? Now remember this, in Maslow's hierarchy of needs, okay, psychosocial needs would be second level priority. So you begin with physiologic needs. So we do away with depression. That's a psychosocial problem. We're left with drooling, clumsiness, cognitive impairment. Okay, with these three now, which one will you prioritize? Okay, you need a functional concept. Always remember, drooling is dangerous because it increases the risk for aspiration. That's a functional concept. And therefore, that gives you a clue that you will have to deal with drooling first. Okay, so when faced with a question that entails differential diagnosis, use the syndromic functional concept approach. Okay, so let's differentiate Parkinson's from Huntington's disease. Okay, I'd like to highlight this class. Please remember this. Okay, now, your Parkinson's disease actually affects the nervous system, specifically the basal ganglia, the part called substantia nigra, where your neurotransmitter dopamine, okay, is usually, okay, produced, okay? And since there's a deficiency in dopamine, okay, inhibition of muscles would be impaired, okay? Such that the main problem for a patient with Parkinson's disease would be motor disturbance like bradykinesia, slowed motor movement, propulsive gait or fascinating gait, okay, muscle tremors, okay, resting tremors, okay. And to reverse that, the most effective medication would be your levodopa. But take note, if a patient is being given levodopa, watch out for the patient's diet. Why? When the patient is on levodopa, administer a low protein diet because protein will diminish the absorption of levodopa, okay. Your Huntington's disease, on the other hand, also affects the nervous system. It also affects the basal ganglia, but specifically the caudate nucleus and the putamen, okay? Those areas that are responsible for cognition, motor movement, okay? So what are the things that I'd like you to focus on in terms of Huntington's disease, okay? To control movement, the drug tetrabenazine or xenazine is given. Then the patient will need referral to a multidisciplinary team, the physical therapist, the occupational therapist, the speech therapist, the psychiatrist, the psychologist, and the clinical social worker. Okay. Now take note, both have genetic basis. The difference, Parkinson's is transmitted autosomal recessive, Huntington's is transmitted autosomal dominant. In essence, you need to refer both patients to a geneticist. Okay. So, and in both conditions, since this may be chronic, depression may result because most chronic conditions results to depression. So remember this functional concept. In both Parkinson's and Huntington's diseases, movement is affected. However, cognitive impairment affects most clients with Huntington's disease, while some clients with Parkinson's develop it. So cognitive impairment is more aligned with Huntington's disease. But the similarity is that both patients with these conditions will have impairment in movement. So in Huntington's disease, aspiration, pneumonia, and heart disease that's stress-related are common complications. Pay particular attention here. Aspiration pneumonia is a complication of Huntington's disease. Okay, now let's focus on the signs and symptoms of Parkinson's disease. Take note, you have this on your handout, and please be familiar. Don't memorize, be familiar. The code is more bad deaths. So you have mood changes, the patient could become depressed and irritable, overstoop posture, rigid muscles, mean cogwheels rigidity, okay? So this would actually have them sometimes with slow movement that progresses to a faster movement, then slow movement again, expressionless face or apathy, bradykinesia or slowed movement, automatic movement loss, meaning they don't blink, they don't smile, and their arm swinging would be limited, okay? Then you have drooling, which could actually increase the risk for aspiration. Dysarthria, so you have to facilitate communication with these types of patients. Excessively clumsy with aching muscles, bowel and bladder incontinence, and then pill rolling tremors. Now take note, the pill rolling tremors could become unilateral and then eventually bilateral. Initially, one hand would be affected, then both hands will be affected. Now, pill rolling tremors or resting tremors occur in patients with Parkinson's disease. However, flopping tremors occur in clients with hepatic encephalopathy. Okay, intentional tremors, meaning when the patient is doing something, that's when the tremors begin. That's characteristic of multiple sclerosis. Then fine hand tremors is characteristics of hyperthyroidism. Fine hand tremors that progresses to coarse tremors would be characteristics of lithium toxicity. And then coarse tremors, okay, you see how Whitney would usually have it? That's indicative of alcohol withdrawal syndrome. So you have to know how tremors would occur in a specific condition, okay? And then you will have speech changes. The patient will have monotone voice or slurring. Since they are depressed, their voice would be monotonous, okay? So low pitch voice. Okay, here's Monica Marjan. Thank you, Ray Gapus. Okay, this is her. That's Monica. She's now in the States. And this is me with another Gapus mentor, Mentor Gem. Okay, joining our students in Nepal. Sujita, thank you, Sir Ray, and the entire team. I'm very grateful to all of you. Thank you. Okay, now let's move on and let's focus on diabetes. And let me make this simple, okay? Primarily, when you say diabetes, the first question that comes to mind is that, what would I study? Would I study about the pathophysiology? Would I study about the signs and symptoms? Would I study about the management? Now remember, on the NCLEX, study first the aspects that are of concern to your would-be patients. So what are the NCLEX issues? These are usually the issues that are being brought to your attention by your patients. So focus on how your patients would react when they are diagnosed with diabetes and how they would alter their life style according to this diagnosis, okay? So always remember the test-taking key, compare and contrast. The question is, sir, what do I need to compare and contrast about diabetes? The two types, diabetes type 1 and diabetes type 2. Ready? So in diabetes type 1, take note, patients with type 1 diabetes don't produce insulin. So there's no insulin, okay? So this develops in childhood or adolescence or before they turn 30 or before they turn 40, okay? So it could be autoimmune in nature.
Hello.
It could be genetic. And sometimes your location, there are patients who are located in some parts of the world where there's an increased incidence of type 1 diabetes. Now, take note, among these factors, which one would you need to focus on? It's family history and genetics. If it runs in the family, there's no way that you can prevent it. All you have to do is to deal with it, accept it, and live or alter your lifestyle according to the diagnosis. Okay. Type 2 DM, patients don't respond to insulin or they don't produce enough insulin. So this is called insulin resistance. How do you picture it? Okay, it's like this. If you view insulin as the key to a house, your house represents your cell. Insulin is the key. In order for you to bring in the groceries, meaning your glucose, to the house, you need to open the house. If you don't have the key, no insulin, that's type 1 diabetes. If you have the key, but it's broken, okay? Okay? So the patients don't respond to insulin. So it's the key is broken, so you can't open the house anyway. That's insulin resistance. That's diabetes type 2, okay? And this usually develops in adulthood, usually above age 35. Some literature say above 45, okay? And the common risk factors would be obesity, inactivity. This could also be genetic. Could be related to environmental factors. Race, like African American, are at higher risk. Latino, American, Indian, and Hispanics. Now, take note, class. This is what I'd like you to highlight. The risk factors. Which risk factors could be common to both? Genetic. Okay. Which risk factor would usually differentiate DM2 from DM1? The age of onset. This is adult onset. This is adolescent onset. Usually DM type 2 patient would be obese. DM type 1 patients are not obese. They're usually thin or of normal body weight. Okay? Okay. So remember, DM type 1 develops fast. DM type 2 develops slowly. Okay, I'm showing you now this illustration. This is the house key. Think about this as your insulin. Your sugar is represented by your groceries. Your body cell is represented by your house. In type 1 diabetes, you don't have a key. So the sugar cannot enter the cell. So the cell becomes hungry. So eventually they overcompensate. That's polyphagia. Okay? And since they overcompensate, they ate so much. So they try to drink fluids, okay, to dilute the sugar, and that would usually lead them to polyuria, okay, because the sugar doesn't go inside the cell. It stays outside where water is reabsorbed from the cell going out to the kidneys for excretion. And since the sugar is not entering the body, eventually the cell is starved, weight loss occurs. So you have now the manifestations: polyuria, polydipsia, polyphagia, weight loss. Okay? So in type 2 DM, the key is broken. Still, the sugar cannot enter the house. So there is insulin resistance. So insulin here is represented by the key. So if you happen to forget what diabetes is all about, just think about the groceries, the house key, and the house. Okay. The primary test for type 1 and type 2 diabetes is glycosylated hemoglobin. It actually shows the attachment, okay, of your glucose to your hemoglobin in the past 3 months, okay? And an A1C of 6.5 and above indicates diabetes. It's also used to determine compliance to treatment, okay? Next important thing, the management of diabetes. Focus on this class, listen carefully. Diet. Now, the best answer, if you're going to be asked what type of diet is best for a diabetic patient, the best answer is a well-balanced diet. Primarily, that is comprised of 50 to 60% carbohydrates, okay? 10 to 20% fats, okay? Sorry, 20 to 30% fats, and 10% protein, okay? So it's a mixture and a balance of carbohydrates, fats, and protein. Okay, and then insulin, specifically your long-acting insulin, Lantus, okay, is being preferred now by healthcare providers. We have a separate video that discusses the different types of insulin. Please pay particular attention. You just have to go into our YouTube channel, Gapos Mentors, and locate my discussion on the types of insulin. That's also NCLEX RN focus. Anti-diabetic drugs, okay? You have your oral hypoglycemic agents, your bigonides like your metformin, okay, pioglitazone or pyazone, and then monitoring of blood sugar at least twice a day, exercise to burn the sugar. Then transplant of pancreatic cell is still under research, okay? This is still under clinical trials as of 2018, okay? Okay. Then ensuring adequate food intake to prevent hypo and hyperglycemia. And this is the most important thing now, scrupulous food care. Now, let me focus on the what if. What if the question would deal with food care of a diabetic patient? Okay. So always remember, what are you going to tell the patient upon discharge? So discharge instruction for the diabetic patient. Avoid going barefoot even if they're inside the house, even if they know that it's clean. Avoiding the use of sandpaper to remove corns or calluses, specifically if they're going for a foot spa. Okay, avoiding lotion in between toes. Don't get this wrong. They are allowed to put lotion on the feet, on the legs, but not in between toes because that becomes a culture medium for bacterial growth. Being observant for cuts, bruises, and signs of nerve damage. Okay, and cutting the toenails straight across and filing the edges. A, B, C. Focus on this. Dream about this. Eat this. Digest this. Okay? Now, let's move on to the next important thing that I'd like to highlight. As we've been saying a while back, go back to the basics. Sometimes we don't know that concepts like negligence needs to be studied for the test. Remember, what is negligence? It's an act of omission or an act of commission. What does that mean? Act of commission, doing something that you should not have done as a prudent person. Act of omission, not doing something that you should have done as a prudent person. What does that mean? If you have done something that you are not supposed to do, that's negligence. If you did not do something that you are supposed to do, that's still negligence. So in essence, to avoid negligence or avoid being charged with negligence, do what you have to do, okay? Within the scope of your professional practice. A lot of people are confused. Sir, what's the difference between negligence and malpractice? Okay, let me clarify this. Negligence is sort of the general, okay? It's actually committed by a person in terms of non-observance of practice, okay? Malpractice, lawyers say, could be a subcategory of negligence. And it is defined as professional negligence. So it's like this. Can a driver, okay, who's not a graduate of a degree and is not a licensed professional, be charged with negligence? Yes. Okay? But if you talk about practice, okay, you're supposed to be a licensed professional within a specific professional group. That's why you have medical malpractice, nursing malpractice. Okay? So, once again, negligence is an act of omission or commission. And a common example is failure to administer antihypertensive on time, and that led to hypertensive crisis. Your failure to administer the antihypertensive is an act of omission, and that constitutes negligence. Now, what about malpractice? It's professional negligence. It's a subcategory of negligence. So this is the general term. This is a category under the general term, okay? So, example of malpractice would be the physician knows that his action can result to injury but proceeded anyway. So here, specifically, you have a physician. So that's medical malpractice. Here in negligence, this is a medical term. There's failure to administer antihypertensive. So this could be, okay, related to the function of the LPN or the RN or the physician or whomever is the caregiver of the patient. Okay, so the caregiver of the patient could be guilty of negligence, but the physician could be guilty of malpractice. So this is a more general term. This is a more specific term. Okay. So let's focus on negligence because that's what matters. Now you know the difference. There are 5 elements of negligence. In order for negligence to exist, there has to be a duty. The accused should be expected to perform a duty to provide care. In order for negligence to occur, there has to be a breach of that duty, which means the standards of care were not observed. That resulted to injury. And there has to be a connection or a correlation between that breach of injury, breach of duty to the injury. So there should be a cause in fact and a proximate cause, which means there's a correlation or a direct link between the negligent act and the injury. And last but not the least, harm. There should be injury, loss, or other expenses. I have a question. Can a patient who was not given a medication, but there was no complication that resulted, there was no harm that resulted because the medication that wasn't given was just a routine dose of vitamin C, can the patient sue for negligence? No, because there's no harm. Okay? But if the patient was asked to pay, if the patient's condition that resulted from the non-administration of medication has resulted to more expenses on his part, on her part, then the patient could actually sue for negligence. So harm or the presence of injury must be there, okay? So remember the 5 elements, they have to be there, okay? So here we go. Here's an example. I love this question. Which of the following situations may potentially constitute negligence? Okay. Administering cyclosporine with grapefruit juice. Anything that comes to mind. People would say, what is that? Cyclosporine or Sandimmune is actually given to post-organ transplant patient to prevent transplant rejection. However, grapefruit juice decreases the absorption of cyclosporine. So, if you administer cyclosporine with grapefruit juice, is that negligence? Yes, there could be harm that could result. Okay? Okay. There will be decreased absorption of the drug, and that could actually entail that the patient could develop complications. You're doing well. Good. Administering clozapine to a patient whose ANC count is 700. Okay, absolute neutrophil count. The normal is actually 2,500 to 6,000. Some literature would say up to 8,000. Okay, your ANC count is important for clients with clozapine because clozapine causes neutropenia. Neutropenia is categorically defined as WBC count below 1,500. Oh, so what happens now? If the patient has ANC count of 700, the patient is already neutropenic. And if you're going to administer clozapine, it will further decrease the ANC. Is that negligence when you administer clozapine to a patient whose ANC count is 700? Yes, you're causing harm. Okay. Administering the next dose of digoxin to a patient with several episodes of nausea and vomiting. Now take note, digoxin toxicity is manifested by nausea and vomiting. If the patient is already having nausea and vomiting and you still administer the next dose, you're causing more harm. So yes, that's negligence. Frequently serving orange juice to a patient with spironolactone. Orange juice is high in potassium. Spironolactone causes potassium retention. So you are worsening the patient's risk for arrhythmia. So yes, that's negligence. Serving high protein diet to a client with levodopa. What did we say a while back? Patients with levodopa should be given low protein diet because if you give high protein diet, the patient would actually have decreased absorption of levodopa. So once again, that's negligence. Administering ibuprofen with meals, that is necessary, okay, to prevent GI irritation. Okay, so administer ibuprofen with meals, that's not negligence. Administering the next dose of lithium carbonate to a 65-year-old with a lithium level of 1.2. Take note, you have here an elderly. In elderly patients, the lithium level should not exceed 1.0. So 1.2 is already high for the elderly patient. So this is an act of negligence. You are increasing the risk of the patient for toxicity. Okay, so be ready for questions such as this. Very, very situational. What is difficult with this question? The concept is negligence, but it's integrated with questions about drugs, about dosage, about food, nutrition, diet, okay, about when to give the medication, about the normal level of the medication. So you have to know how to integrate your concepts. Okay. Now, this is something new. I know some of you may not be so inclined about studying faith and spirituality for the test, but this has been one of the new things that are integrated to the test some 5 years back, okay? Faith and spirituality. First and foremost, let's begin with the idea, what is faith? It serves as a person's guiding principle, something that you believe, okay? Serves you a purpose. Spirituality refers to one's recognition or belief of the presence of a greater power. It is related to one's sense of peace and purpose in life. Spirituality does not always mean religiosity. It's about your relationship with the Supreme Being. It's about your relationship to yourself. Okay? Okay. Here's a question. Which of the following ways reflect expression of spirituality? Okay. Engagement in social action. If that would actually bring you peace to yourself, you are doing something for others, okay, go ahead. Okay, thinking about the values one would live by, yes. Okay, walking your dog to a park which you find attractive, yes. That's spirituality. It promotes peace within yourself. Sitting quietly still for a few minutes in a garden, yes, that promotes peace. Reading books about spirituality, yes. Okay, here you go. Joining a trendy class, okay? This is how it goes. Trendy dance class to develop a sense of belongingness. This is not spirituality because you're joining it because it's a trend, not because you find fulfillment in it. So that's an X. Doing yoga, yes. Okay? So always remember your functional concept. So test-taking key, reflect on the concepts. Don't just memorize definitions, okay? So remember, to succeed in life, you need two things. One, ignorance. Because you're ignorant, you don't know what to study. And that will actually push you to study some more. And second, you can develop this by joining our class regularly. Confidence. If you have ignorance and confidence, then you're bound to succeed. That's the recipe for success. Look at this question. Somebody is asking his daddy, "Daddy, how do stars die?" The daddy answered, "Drugs normally." What's the problem here? The daddy misunderstood the word stars. The kid is asking about the stars in the sky, but the daddy misinterpreted the stars as movie stars. That's why he said drugs normally. This is a classic example of being unable to reflect on a situation. And you should avoid this when you're preparing for the NCLEX. Okay? Okay. So let's talk about care of ourselves. You're not included, okay? I'm a candidate for this, okay? I've long accepted that. Your generation is something that you need to enjoy. What future am I talking about? My future has been yesterday. That's why I'm doing this. I'd like you guys to succeed, and I will be happy to see you succeed by joining our classes, okay? So let's begin with care of the elderly. Oh, by the way, remember in our QuickFix session 1, I talk about Pasita, who was my student at age 60, okay, when she passed her foreign-based exam and she was happy to get employed in the US, okay. So there's no specific demarcation of when learning should occur. The most important thing is we learn every day. Learning is a journey. Learning is a lifelong and a life-wide process. Okay, and both of us are considered learners. I consider you as a learner. I consider myself as learners, as a learner. So all of us are learners. Okay. Okay. So here's a question: which of the following expected normal changes are observed in elderly patients? Keyword here: normal changes. A lot of nurses are committing errors on questions like this. Let's begin. Difficulty hearing high-pitched sounds. Yes, elderly patients would usually be are more able to adjust to low-pitched sounds. Okay, so high-pitched sounds, they have difficulty because of presbycusis. Okay, age-related hearing abnormality. Okay, decreased hearing. Yes, sometimes they need artificial tears, which is very important. Next, increased peripheral resistance and decreased elasticity of the blood vessels. Yes, the increased peripheral resistance leads to high blood pressure. Okay. Increased sensitivity to glare. Yes, that's why, think about these colleagues, what do you need to check when you're visiting the room of an elderly patient? The lights. Okay, because if they have fluorescent lights, that increases potential to injury because they're sensitive to glare. When their lights is just so bright in the room, what happens? They will walk with their eyes closed, and that increases the risk for injury. So yes, they are sensitive to glare. Increased number of cherry angiomas. Now, what are cherry angiomas? Okay, cherry angiomas are mole-like, reddish skin growth. Okay, now, is this related to cancer? No, these are usually benign, non-cancerous lesions, okay? They are usually treated with a laser surgery or cautery. However, take note, as you grow older, you'll have more of this, usually on the trunk and the arms, okay? So this is one indication that you're already getting old when you have a lot of those red spots. I used to have none of this, now I have several, okay? So when you reach age 40 onwards, then you will have cherry angiomas. Once again, is that normal, expected? Yes. Okay, increased gastric motility. Now remember, there's a slowing of function, and that's the reason why elderly patients have constipation. That's why you have to provide them with exercises, okay, increase roughage in their diet. So this is not expected. And last but not the least, this is where a lot of people could have gotten the question correctly, but eventually they get it wrong because they think that decreased cognitive function is normal in the elderly. No, 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 no. Decreased cognitive function indicates beginning signs of dementia. So when your patient, it's wrong to think that when you grow older, you will forget a lot of things. No, 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 that's not normal. That's indicative of dementia. Okay, so this is not expected. Okay. So for elderly clients, the use of incandescent light is preferred over halogen lights that increase glare. Take note. So if you visit the patient, now what if a question would ask you, if you visit the elderly patient's room, which one will you recommend to change? Change the halogen lights to incandescent lights because they're sensitive to glare. Excellent. Okay, now let's talk about a common problem of elderly patients. And this is about, take note of this class, falls. Okay. And what is the most common cause that increases the risk for the elderly's falls? Take note of this class. Medications, specifically antihypertensive medications, in which patients would usually have dizziness after taking the drug. So instruct them to sit and relax for at least 30 minutes before moving around or standing upwards, okay? Or dangle the feet before standing up from a lying down position, such that you prevent dizziness, okay? So a history of previous falls could actually increase the risk for falls, as well as difficulties with mobility, balance, incontinence, and reduce cognitive ability. Okay, now take note. So when you're admitting an elderly patient, it's expected that you use fall risk assessment scale as an essential part of assessing a patient's risk for falls. And this is where your Morse fall scale would come in. Now take note. What I'd like you to know about your Morse fall scale would be the 6 items that you need to focus on assessment. History of falling, secondary diagnosis, ambulatory aid. What do you mean by furnitures? Assess if the patient ambulates by holding onto furnitures. This is what is meant by ambulatory aid furnitures. Then if they're using heparin lock, gait transferring, and mental status, okay? Now remember, the higher the score, the more at risk the patient. So this is how it's interpreted. 0 to 24, no risk. 25 to 50, low risk. Above 51, high risk. Okay? Okay. Next important thing that I'd like to highlight, that a lot of you, maybe you're not focused on understanding fetal heart rate deceleration. When you say deceleration, it means slowing. Okay, deceleration means slowing. What happens to the fetal heart rate? Here's a sample question. Look at this class. Look at this. Okay, I'm so excited to show you this. Which of the following patterns of fetal heart rate does not indicate a need for further evaluation from the nurse? 1, slow onset at the start of contraction with slow return to baseline with the end of contraction. And you would say, WADA. 2, fall at the beginning or after the peak of uterine contraction and return to baseline after the end of contraction. And you will say again, WADA. Number 3, acute fall with rapid downslope followed by recovery. You would say WADA, WADA, WADA. And 4, rate of less than 80 beats per minute for at least 3 minutes to say, I give up. I leave it up to God to guide me with the Holy Spirit to choose the correct answer for this question. But that's not the way how to do it. Okay? Give it a fight. Never give up. Never give up without a fight. Remember what we said a while back in our session number 4? Okay. Options actually refer to the definitions of the different types of abnormalities of fetal heart rate. When there's a slow onset at the start of contraction with slow return to baseline, okay, this is actually what they call early deceleration. The key phrase is at the start of contraction. So if there's slow fetal heart rate at the start of contraction, that's early deceleration, okay? Fall at the beginning or after the peak, the keyword, peak of uterine contraction, and return to baseline after the end of contraction. Okay, this is the keyword here. After the end of contraction, okay, this is late deceleration. Acute fall with rapid downslope followed by recovery, this is variable deceleration. Rate of less than 80 beats per minute, this is fetal heart rate bradycardia. Okay, the question now. Sir, this is difficult. I'll make it easy. The question is, which of the following patterns of fetal heart rate does not indicate a need for further evaluation? So what are we supposed to look for is a fetal heart rate pattern that tells us that the baby is okay. Okay? That does not indicate a need for further evaluation. How do we go about this question? Okay? Let me first simplify before I explain why the answer is 1. Here is actually your pattern. And the question, which area should the nurse assess for deceleration? Okay, B, the one labeled B here, corresponds to the pattern of uterine contraction. Increment, acme, decrement. Increment, acme, decrement. Increment, acme, decrement. That's the pattern of uterine contraction. A indicates fetal heart rate pattern. Okay, when you have a downslope, it simply means slowing. So here, you have a fetal heart rate of around 120. take note, at the peak of contraction, the fetal heart rate slows, okay, and returns to baseline towards the end of the contraction, okay? So this indicates late deceleration. Okay, now, to compare early, late, and variable deceleration, you have this in your handout, okay? Let me compare for the benefit of all of you class. So let's talk about early decelerations. Early decelerations are due to fetal head compression. Okay, the image that you will see would be mirror image. Look, why is it called mirror image? The image here is the same as this image. Okay, how do we know that it's early deceleration? Again, we go back to your uterine contraction pattern. Okay, if the slowing of the heart rate, which is manifested by the downslope, yung pagbaba, okay, here, occurs before the peak, okay, it occurs before the peak, then that's early deceleration, okay? And you have two patterns here that are almost similar. It's called mirror image. Now, is this normal? Yes, there's no intervention necessary because the fetal head is usually compressed during delivery. So it's expected that you will have early deceleration because early deceleration is due to fetal head compression. Sabi nga sa Tagalog, ang lahat ng ulo na pumapasok sa cervix naiipit. Diba? So early deceleration is due to fetal head compression. Okay, next. Okay, tandaan mo na lang yon, our Filipino friends. So, every head that enters the cervix gets compressed. So in Tagalog, lahat ng ulo na pumapasok sa cervix naiipit. Okay? Next, late deceleration is due to uteroplacental insufficiency. The keyword late, LA, placental insufficiency. So this could be related to aging placenta. Okay, it's called reverse mirror image. Why is it called reverse mirror image? Look, in the early deceleration, the slowing of the fetal heart rate occurs before the peak of uterine contraction. In late deceleration, the slowing of the fetal heart rate occurs at the peak and towards the end of contraction. Isn't this the reverse of this? Yes, that's why it's called reverse mirror image. Okay, and your priority is to administer oxygen, usually at 10 liters per minute, and then put the patient to left lateral recumbent position. Okay, and then variable decelerations is due to compression of the umbilical cord. Could be due to premature rupture of membranes, could form a letter U, V, or W, may lead to acidosis and distress. Look, you have, this is actually a W shape. So it could be U, V, or W. And look, the fetal deceleration could, this one occurred towards the end of the contraction. This one occurred at the peak of the contraction. So it's not consistent. It's not like early deceleration that it only occurs before the peak. Late deceleration occurs at the peak towards the end. Variable deceleration, sometimes it occurs at the peak, sometimes it occurs towards the end. Okay? The intervention could be similar to late decelerations. Now, what do I want to highlight? Which among these class on the NCLEX would be the least priority? Early deceleration, because you don't need interventions. So which among these indicates fetal distress? You have it here. Variable deceleration. Which among these indicates premature rupture of membrane? Variable deceleration. Which among these is characterized as mirror image contraction? Early deceleration. Which among these is characterized as reverse mirror image contraction? Late deceleration. Which among these is characterized as U, V, or W-shaped contraction? Variable deceleration. Which is due to cord compression? Variable deceleration. Which is due to head compression? Early deceleration. Which is due to placental insufficiency? Late deceleration. That's the way to do it. Okay? Now, you can go back to this again, okay, through our YouTube channel. So, what would be your interventions for non-reassuring patterns of fetal heart rate or for patients having late and variable decelerations? First, call for assistance. Then administer oxygen, position, left lateral or knee chest would be okay. Administer D5LR in bolus. Perform vaginal examination. You have to include this to assess whether the labor is progressing normally. Then fetal scalp stimulation and discontinue the use of oxytocin because a patient who's having deceleration may not withstand the labor process, okay? So late deceleration with loss of variability is a danger sign and requires immediate delivery. So what's your priority if there's late deceleration with loss of variability? Okay, prepare the patient for immediate delivery. Ominous or danger patterns of fetal heart rate include persistent late deceleration with loss of bit-to-bit variability and non-reassuring variable deceleration. Okay, in other words, late decelerations and variable decelerations are ominous patterns or danger signs. Okay, you need to refer it immediately. Okay, fetal tachycardia.
Damit ko ba rin mo? Bobo naman ito. Ano nangyari sa'yo?
Okay. Fetal tachycardia. Sorry for the interruption. This is what I'm going to do. If somebody interrupts, I will not talk so that you would be able to understand what I'm saying, okay? So when you say fetal tachycardia, the fetal heart rate is usually more than 160 beats per minute. And if it's from 160 to 180, then that's considered mild. Okay, more than 180, severe. And then if it's more than 200, then you have tachyarrhythmia, okay? Fetal bradycardia is when the fetal heart rate is less than 120. Okay, what do you mean by saltatory variability? Saltatory variability means not gradual. So immediate downslope, or there's leaping, pabigla-bigla in Tagalog, okay? Variable deceleration is also non-reassuring, and late deceleration. So if you will be asked, which of the following are danger signs, okay, in a pregnant patient? Select all that apply. Then you can answer fetal tachycardia, fetal bradycardia, variable deceleration, late deceleration, okay? So causes of placental dysfunction associated with late deceleration could be associated with maternal hypotension, uterine hyperstimulation. So assess if the patient has been taking herbal remedies, okay? Okay, specifically those who would want their labor to progress at a faster rate, okay? Then post-date gestation, preeclampsia, chronic hypertension, and diabetes mellitus, okay? So let's move on now to, once again, another common important thing that the nurse should know. Take note of this, okay? Depression. Okay, what do you need to remember about depression? The risk for suicide. That's one of the most common safety risks in a depressed patient. Especially now during the pandemic, you will see a lot of spike in terms of suicidal attempts of patients, okay? So risk for suicide increases as depression begins to lift. So when is this? Usually, when we administer antidepressant medications, it would take 2 to 3 weeks before initial effects occur and 3 to 4 weeks before the full therapeutic occurs. In which case, a month after the start of the medication regimen, patient becomes at risk for suicide. So you have to be very, very mindful of the patient's behavior. So if the patient all of a sudden have mood swings, or there's a shift from being lonesome to being happy, that indicates that depression has lifted. The patient now has the energy to carry out a suicide plan, okay? And usually elderly patients are successful on their first try. So chronically ill male elderly patients are more at risk to suicide. So patients with Parkinson's disease who are depressed, chronically ill, would have more risk to suicide, okay? Would have higher risk to suicide, okay? Then what are the suicide risk factors? You have the code suicidal. Sex, remember, more women attempt suicide, but more men commit suicide. Unsuccessful previous attempts. So if there are previous attempts, that increases the future risk for attempting again. Identification with the family member who committed suicide. If one member of the family did it, expect another member would do it also, sorry. Chronic illness, okay? Chronic conditions like diabetes, Parkinson's, Huntington's could actually come with depression, suicidal tendency. And then depression, then age. Those who are elderly are most at risk. And loss of a loved one, whether real or imagined, loss is a risk factor. Take note of this, whether real or imagined loss, okay, is a risk factor. Let's move on. This time, whew, we're on a roll. We'll talk about cardiac enzymes in MI. Now, there's a funny story about this because the answer to the question, which of the following cardiac enzymes elevates first when a patient develops MI, it depends on the decade of your graduation. Because during our time, we have yet to talk about myoglobin, we have yet to talk about troponin, there's only creatinine kinase, Okay, so that's the first to elevate. But then after they have identified troponin, so the answer is now troponin. And then after they have identified myoglobin, so the answer is myoglobin. So the answers actually, okay, reflects, okay, current evidence. So let's get through it. Let's try answering a sample question. In the emergency department, a client with myocardial infarction was admitted. Which one should the nurse expect to elevate first? This is what I'm trying to tell you guys. The answer of a nurse question represents their decade of graduation, which simply means that, okay, those who graduated during my generation would answer creatinine kinase. Those who graduated after my generation would answer troponin, and the generation after that, myoglobin. But those who will answer LDH simply means you did not read. Okay. That's not the first to elevate, not unless the situation says after a week of MI. That's the time that you can answer LDH because it's something that could remain elevated for more than a week. Okay, like troponin. Okay, so let's move on. So that's myoglobin. Myoglobin increases within 2 to 4 hours. Okay, but some would actually say that even in conditions in which there is muscle tissue damage like injection, myoglobin could potentially increase. That's why some people would not say that it's specifically increasing for patients with myocardial infarction. It could be indicative of cardiac damage, but it is not necessarily specific for it. Okay, so myoglobin increases within 2 to 4 hours after MI. It peaks at 6 to 12 hours, returns to normal within 24 to 48 hours or 1.5 days. Troponin increases an hour later, 3 to 4 hours after MI. It can be elevated for 2 weeks. Okay, so if myoglobin has returned to normal in 1.5 days, troponin could still remain elevated for 2 weeks, such that if the patient is already having MI more than 1 week, then the answer, which one would be elevated, you will answer troponin. Okay, because myoglobin returns to normal in 24 to 36 hours. Okay? CKMB increases within 3 to 12 hours after MI, peaks within 24 hours, returns to baseline in 2 to 3 days. Once again, your CK returns to baseline earlier than your troponin. And the LDH increases within 24 hours after MI. It returns to normal in 8 to 12 days. So almost similar as that of your troponin. So let's summarize. Myoglobin increases in 2 to 4 hours, returns to normal in 24 to 36 hours. Troponin increases in 3 to 4 hours, returns to normal in 14 days. CK increases in 3 to 12 hours, returns to normal in 2 to 3 days. LDH increases in 24 hours, returns to normal in 8 to 12 days. Let's process. So if you have a question that says, which enzyme is elevated in a patient who already had MI, okay, for 13 days. Okay, so your LDH returns to normal in 12 days. So 13 days, this could have normalized, this could have normalized, this could have normalized. So the answer would be troponin. Okay, but if you'll be asked, which one initially increases? Hands down, the answer would be myoglobin. It's the fastest to increase within 2 to 4 hours. Okay, so if you'll be asked to arrange this in order, what will you have? You have a question like this. Which is the correct sequence of elevation of the following cardiac enzymes in a client with MI? You begin with myoglobin, troponin, creatinine kinase, and LDH. Okay? Okay. That's the sequence in terms of elevation. Okay? But what if, remember what if, NCLEX would ask you the reverse. Arrange the following in terms of which goes back to normal first. Okay, so which goes back to normal first? Once again, it's gonna be myoglobin, followed by your CK, and then LDH, and then troponin. So which goes back to normal first? Myoglobin. Which goes back to normal last? Troponin. Which elevates first? Myoglobin. Which remains elevated the last? Troponin. Okay? So you always have to remember your concepts. Once again, which elevates first? Myoglobin. Which returns to normal first? Myoglobin. Okay? Which elevates last? Okay? You will have to answer which elevates last? LDH. Okay? Which returns to normal last? Troponin. Okay? Okay. So if you arrange it according to elevation, myoglobin, troponin, CK, LDH. If you're going to arrange it according to its return to normal, it's going to be myoglobin, CK, LDH, troponin. Excellent. You're learning how to process. Okay, good. Okay. Now, a lot of people are saying, oh my God, I saw an EKG pattern again. Okay, this time I'd like to highlight second degree AV block. Okay, one important thing I have to remind you. Don't get scared when you see an EKG pattern. Now, there's a full video around 1 hour, 38 minutes that I prepared for simple EKG interpretation that covers everything in a simplified NCLEX RN focused format. You're gonna see it in Gapus Mentors, okay? Please check it out in our YouTube channel, Gapus Mentors. So watch over it, dream about it, eat it, digest it, drink it, okay? Okay, so if you talk about second degree AV block, atrioventricular block, what should come to mind? Think about PR interval, okay? Time it takes, PR interval shows the time it takes, okay, for the specific signal coming from the atria reaches the ventricles, okay? In essence, it shows you the distance from the time the atria reacts to the time the ventricle reacts to that signal, okay? So, if you see AV block, think about the PR interval. Okay. Let's try to evaluate an example. So the ECG tracing below indicates, oh, this is kind of difficult because if you don't have a background on ECG tracing, okay. 1 square is usually equivalent to 0.04 seconds, okay? The normal PR interval is 0.12 to 0.20 seconds, so which simply means 3 to 5 small squares, okay? So from the P to the R interval, okay, there has to be 3 to 5 okay, small squares. This one, okay, but look at this. You have here the P, then you have 1, 2, 3, 4, 5, 6. So this is already prolonged. So what did we say? When you have prolonged PR interval, then you have, okay, look, this is progressively prolonging. Then you have a second degree AV block. From normal, then it progressively prolongs. Okay, so a progressively prolonged PR interval, this is a functional concept, indicates second degree AV block. Okay, so the answer, second degree AV block. Look, the first distance, 0.20 seconds. The second would be 0.24. And the third, okay, 0.28. Okay, because 1 small square is 0.04. Okay. Okay. So question, how does second degree type 1 AV block differ from second degree type 2 AV block? So this is just trying to highlight what you need to remember for those who are taking the test for the month of October. For those of you who want a comprehensive discussion of ECG interpretation, I have a separate video. Please do visit Gapus Mentors on YouTube, okay? And please to sponsor our nursing scholars, just finish watching the video ads, okay? So for second degree AV block, there's progressive lengthening of the PR interval. You have a regularly irregular rhythm, and the P wave ratio, meaning the presence of the P wave to QRS, could be 1:1. Okay, so the rate is normal, P wave rate is normal, QRS duration could be normal. Okay, so here's a second degree AV block type 1. Okay, you have a progressively prolonged PR interval. Look at this. Okay, progressively prolonged. Okay, and then you have a QRS drop. Okay. Okay. So second degree AV block type 2, on the other hand, you have the P waves that may not be followed by QRS. So you have a lot of P without the QRS. You have a prolonged QRS, and the PR could be normal or prolonged but constant. So it's not progressively prolonged. The rhythm could be regular, rate could be normal, P to QRS ratio would be 2:1, which means there could be 2 P waves to 1 QRS. P wave rate normal but faster than the QRS rate. This is how it looks. So look, you have the absence of a QRS. You have several P wave, then no QRS. So if you have this, several P waves, no QRS, second degree AV block type 2. Okay? Okay. So let's summarize. So if you're going to compare, this is in your handouts, type 1 second degree and type 2 second degree. The rhythm for type 1, it's irregular. For type 2, it's regular. The PR interval, progressively lengthened for type 1. Normal or prolonged but constant, meaning it's not progressively changing. So if the first distance is 0.20, the second, if the first distance is 0.24, the second distance would be 0.24, and the third PR distance again is 0.24. So that is prolonged but constant. Here in type 1, the first PR distance would be 0.20, the second would be 0.24, the third would be 0.28. So you see it's becoming progressively lengthened or prolonged, okay? And then for QRS, it's normal in type 1, it's prolonged in type 2. And the P wave ratio is 1:1 and 2:1 for type 2, okay? So once again, for you to be able to understand this perfectly, you have to check on my ECG interpretation guide that's so easy to understand. It's just 1 hour, 38 minutes. It covers everything that you need to remember for your NCLEX test, okay? So let's show and do a side-by-side comparison. So look at type 1, okay? So you have the PR distance, PR, which is progressively prolonged, okay? In type 2, okay, the P to R, here's the P to R, okay? It's prolonged, but it's not progressive. So almost equal prolonged distance, okay? And then you have P, and then an absence of QRS. So when you have several P, then an absence of QRS, then that indicates type 2. Okay, so the symptoms of second and third degree heart block includes, remember, FFDSC, fainting, fatigue, dizziness, shortness of breath, and chest pain. And this is what I'd like to highlight. If the patient is asymptomatic, no specific therapy is needed, okay, in the pre-hospital setting. However, as low heart rate may be indicative of complete heart block, in which case, if there's complete heart block or third degree heart block, then usually atropine sulfate, okay, is usually given for complete heart block. The purpose, to increase the heart rate. And for first degree AV block, no treatment is indicated for asymptomatic patients. For those at risk for higher degree heart block, take note, second degree heart block, atropine or isoproterenol can be used, or placement of cardiac pacemaker. Placement of cardiac pacemaker. I'd like to highlight something, class. If you will be asked on the test on what is the purpose of administering atropine sulfate in a client with complete heart block, your answer would be to increase heart rate. To increase heart rate, okay? So a pacemaker is usually indicated when the heart rate is too slow, while an implantable cardioverter defibrillator, that is your ICD, is indicated when the heart rate beats too fast in an erratic way. So your ICD is used to terminate abnormal heart rhythm. Your pacemaker is used to facilitate normal cardiac contraction. An ICD could sometimes also function as a pacemaker. Okay, with that basic understanding, remember this, class. What are the things that you need to remember for your exam? Okay, this. A client with pacemaker insertion is instructed by the nurse to, again, this is focusing on the discharge instruction for the patient. 1, report hiccups to the healthcare provider. Yes, hiccups indicates, okay, that the battery, okay, of the pacemaker, okay, could be compromised. Okay, so the patient's pacemaker would need change in battery. Notify healthcare provider if redness and drainage at insertion site occurs. So this is a poorly managed insertion site. There's an infection. Then maintain diary of daily pulse rates. Take note of this. Situation, okay, should be reported. Avoid contact sports, okay, because of the implant. Okay, inform airport security that he or she has a pacemaker, because, you know, this could actually trigger the metal detectors, okay? So they will be asked to enter through another means, okay? Use cell phones on the side opposite the pacemaker and wear, sorry. So we put a check. Okay. Now, wear tight-fitting clothing? No. We have to instruct the client to wear loosely fitting clothes. Okay. And somebody who is listening to MP3 should not be positioning his head over the pacemaker area, because the pacemaker will, the earphones could actually interfere, or the MP3 could interfere with the pacemaker function. Okay. So, we're moving so fast, and I like this because there's kind of like a faster change in terms of the topics. Okay, I'm just actually welcoming some of your friends back. Okay, let's talk about hemophilia. Okay, so hemophilia is an X-linked genetically transmitted disease that is transmitted by the mother to the son. Okay, so in other words, the mother, anyone who is a female, becomes a carrier, and who is affected? The son. Now, there's a form of bleeding disorder similar to hemophilia. It's called von Willebrand's disease that affects both male and female offspring, okay? But let's focus ourselves on hemophilia. Okay, focus on hemophilia. So it's an inherited X-linked bleeding disorder due to deficiency of factor VIII, which is type A hemophilia, or factor IX, type B hemophilia, otherwise known as Christmas disease. Okay, so let's sing Merry Christmas. Okay. Okay. Now, the manifestations of hemophilia includes, remember, he. The first hemarthrosis, or bleeding in between joints. So if a patient is actually having hemophilia, they will complain of pain in their joints. That could signify there's bleeding. Now, what if the NCLEX, remember you, what if the NCLEX would ask you in which joints will hemarthrosis usually be assessed? Okay, ankles, knees, elbows, including wrists. Okay, so select all that apply: ankles, knees, elbows, including wrists. Okay, hematoma could be formation of blood underneath the tissues. Okay, hematochezia, excretion of blood. Hematuria, urination of blood. Now, pay particular attention, class, that your hematuria could sometimes be described as the patient having tea-colored urine or brownish colored urine. Or if the patient is having hematuria, the patient would actually describe it as cola-colored urine. So there's a darker coloration to the urine, okay? Next, hemorrhage after circumcision, okay, as well as after injection or tooth extraction. So you would notice that these patients would usually have prolonged bleeding after circumcision, injection, or tooth extraction. And this could actually tell you that patients, okay, with hemophilia will show this risk factor when they are being circumcised. Okay. So treatment for hemophilia entails replacement of the missing clotting factor, which means if you have the type, when you have the absence of factor VIII, then factor VIII will be given, usually slow IV push or continuous infusion. And up to when? Usually until the bleeding subsides, okay? And then the same is true for factor IX, okay? It's administered to patients until the bleeding subsides, okay? So that's how people would be coping with hemophilia. Okay, so let's move on. So always remember to ask why. Always have to know the rationale, okay? Okay. This is a game. Could you tell me why Superman has an S on the outfit? Could you tell me why Superman has an S on the outfit? Come on, put your answer on the chat box. What's your interpretation why Superman has an X on the outfit? Send she, what's this, special? I'm super, I'm sexy, sperm. Superhero. What does the S mean? Super sperm. Oh no, sensual, danger, sexy. Let me tell you, it could be misinterpreted in a lot of ways, okay? It could mean that my size is small. Whatever size is he referring to. Or it could mean that my clothing size is small because there's no medium anymore, okay? So it could be misinterpreted in a lot of ways. That's what I'm trying to say. When you're doing syndromic approach to question analysis, there's a tendency to misinterpret data. And to avoid that, you have to familiarize yourself with the manifestations of specific conditions, okay? Okay, so let's now focus on comparing social anxiety disorder, what is usually what was known before as your social phobia, from agoraphobia. Wow, what's the difference? Okay, first, social phobia is fear of being negatively evaluated in social situations. You hate about being put in a situation where people could potentially judge you. Okay, agoraphobia, on the other hand, okay, is fear of being in a situation where escape is difficult. Agora means market, crowded areas. So if you fear being in a crowd, then you have agoraphobia. If you fear being in an area that you can potentially be judged, then you have social anxiety disorder. For both conditions, okay, the treatment would involve cognitive behavioral therapy. Okay, for social anxiety disorder, we teach them social skills training. We administer selective serotonin reuptake inhibitor like paroxetine, anti-anxiety, beta blockers, and take note, kava, an herbal remedy which is anti-anxiety like valerian. But you don't give kava if the patient's already taking anti-anxiety. Why? It worsens sedation, and that could lead to respiratory depression. Okay, now, how would you know that your patient with social anxiety disorder and your patient with agoraphobia is improving? There's one thing. When they attempt to deal with their behavior. How? Since a patient with agoraphobia fear being in a situation where escape is difficult, they would just usually love to stay at home. They stay at home, they read books inside the house, they don't get out. But when they begin to hold the knob of the door, okay, just holding it, that's a sign of improvement because they're dealing with their behavior, okay? And you would know that they have fully dealt with their behavior if they are now capable of going out of the house, going to the garden, in the backyard, and read a novel, okay? Which simply means they have dealt with their fear properly. So, here's a functional concept. Behaviors that indicate a client's attempt to overcome fear is an indicator of positive improvement. So even if they hold the knob, then they experience sweating and palpitation, that's still a sign of improvement. The attempt to deal with the behavior by holding on the knob, getting out of the house, is already a sign of improvement, okay? Now let's talk about, I love this, Guillain-Barré syndrome and myasthenia gravis. Now, this is the point in time when I would like you to focus on your handouts because it's very, very difficult to understand this without you holding on to what I prepared as your learning tools, okay? And I will process this with you guys, okay? You will enjoy, okay? And you will understand this in the simplest possible way that you will marvel at how you mastered it eventually. Okay, so let's talk about these two disorders. Guillain-Barré syndrome actually involves the peripheral nervous system. In fact, you have inflammation of the peripheral nerves. You know for a fact that your peripheral nerves is actually present. It innervates, okay, your body, okay, specific body parts. And there's a discussion of the different, in relation to this, peripheral nerves, there's a discussion of the different cranial nerves, okay, which is also a mainstay in our YouTube channel. Please do subscribe to Gapus Mentors. You will actually have our videos there for your use when you're preparing for the NCLEX. If you want to ask me which videos do you need to watch because you're preparing for a specific month or date of your NCLEX exam, please don't hesitate to send me an email and I would gladly help you out, okay? Okay, so your Guillain-Barré syndrome is acute. Sometimes this is triggered by exposure to a viral infection. Like you've been exposed to a friend who had chickenpox, okay? And all of a sudden, the autoimmune reaction was triggered. And what results? There's muscle weakness. And what happens in Guillain-Barré syndrome? The muscle weakness could be, take note, ascending, descending, and mixed type. Okay, now, some of you would say, I am taught in school that it's just ascending muscle weakness. No, 50% of the cases in Guillain-Barré syndrome, the patient will manifest ascending muscle weakness, which means from the lower extremities going up. Okay, and that occurs after exposure to upper respiratory tract infection, viral infection, or GI infection. Okay, descending muscle weakness, which means it could start from the upper extremities going down, is present in 14% of cases. So this is 50%, this is 14%, and approximately 30 to 35% would manifest a mixed ascending and descending type of muscle weakness, okay? And because of that, the patient would actually have respiratory difficulty. And apart from respiratory difficulty, remember these 4 Ds. You have double vision, difficulty breathing, difficulty speaking, chewing, swallowing, difficulty with bowel and bladder control. And sometimes because they don't move, because of the muscle weakness, they become prone to deep vein thrombosis. So they become bedridden. So you'll have to administer your heparin to prevent deep vein thrombosis, or for maintenance, warfarin. Okay, a variant of Guillain-Barré syndrome is known as your Miller-Fisher syndrome. Okay, so if you read about or encounter Miller-Fisher syndrome, it's a variant of Guillain-Barré syndrome. Now, let's compare myasthenia gravis from Guillain-Barré syndrome. Okay, what did we say? Guillain-Barré syndrome affects the peripheral nervous system, specifically the peripheral nerves. You have inflammation of the peripheral nerves brought about by acute autoimmune infection related to either upper respiratory tract infection, exposure to viral infection, or gastrointestinal infection. In myasthenia gravis, it involves the neuromuscular junction. It's the point at which your brain signals, okay, facilitated by acetylcholine, okay, and your muscle meets. So the brain tells you muscle moves. So how will the muscle move? It would depend on the availability of acetylcholine receptor sites. So it's like this. The brain says muscle move. So your acetylcholine will bring that signal to the muscle. And the muscle should have adequate receptor sites to respond. What happens when the receptor sites are inadequate? Then you have myasthenia gravis. Even if the mind is saying muscles contract, muscles contract, muscles contract, if you don't have adequate acetylcholine receptor sites, then the muscles would not contract. Then that leads to development of weakness. Now, let me differentiate this. An absence of acetylcholine is associated with Alzheimer's. An absence of acetylcholine receptor sites, that has to be complete, acetylcholine receptor sites is associated with myasthenia gravis. Okay, so myasthenia gravis is also autoimmune. That the difference with Guillain-Barré is that it's chronic, whereas Guillain-Barré is acute. Okay? Now, muscle weakness in myasthenia gravis weakens, okay, sorry, the muscle weakness worsens, okay, with use. In essence, you don't push the patient and make the patient vulnerable to fatigue if they have myasthenia gravis. Why? So if the patient who has myasthenia gravis keeps on talking over the phone before eating, eventually the muscles that they use for eating is the same as the muscles that they use for talking, so it will increase the risk for aspiration. So what activity is not indicated for patients with myasthenia gravis before meals? Talking over the phone for long periods, because they make use of the same muscles. Remember, muscle weakness that worsens with use characterizes myasthenia gravis. Okay, now, to compare it again with Guillain-Barré, the muscle weakness in myasthenia gravis is descending. So we also have descending muscle weakness in Guillain-Barré. The difference is, in Guillain-Barré syndrome, the descending muscle weakness begins with the upper extremities going down. In myasthenia gravis, the descending muscle weakness begins on the face going down. That's the reason why in myasthenia gravis, you have ptosis or drooping of the eyelids, okay? Double vision, difficulty breathing, difficulty speaking, chewing, swallowing. Question. I have a question. What symptom would differentiate myasthenia gravis from Guillain-Barré syndrome? Okay, drooping eyelids. What symptom would differentiate Guillain-Barré syndrome from myasthenia gravis? Difficulty with bowel and bladder control. Next, what about if you're given a situation with syndromic approach? Here comes a patient with descending muscle weakness, double vision, with difficulty with bowel and bladder control. Bingo, that's Guillain-Barré syndrome. But if you have, as being presented the question, a patient with muscle weakness, okay, that is descending, but with drooping of the eyelids, bingo, you have myasthenia gravis. What about if you have a question that's select all that apply format that's going to ask you which symptoms are common to both Guillain-Barré and myasthenia gravis? So you'll have muscle weakness, yes. Descending muscle weakness, yes. Ascending muscle weakness, no. Mixed type, no. Double vision, yes. Drooping eyelids, no. Difficulty breathing, yes. Difficulty speaking, yes. Difficulty chewing, yes. Difficulty swallowing, yes. Difficulty with bowel and bladder control, no. That's specifically only for Guillain-Barré syndrome. That's how you should process the information that you are being presented here, okay? So let's move on. So let's process. So in Guillain-Barré syndrome, usually the intervention would involve the diagnostic test, lumbar puncture, and electromyography. Now, the patient would usually will be asked to contract and relax the muscle as needle is inserted to identify the electrical activity of the muscles. Now, remember that there is no specific cure for Guillain-Barré syndrome. Okay, plasmapheresis is usually done. This is when the unhealthy plasma is changed with the healthy plasma, okay? And then IV immunoglobulin therapy, pain medications, because sometimes pain occurs in Guillain-Barré, and of course, blood thinners. Remember, they are prone to deep vein thrombosis. Okay, next. Okay, your myasthenia gravis, you have your tensilon or endrophonium test. Your endrophonium is a short-acting medication that reverses muscle weakness within 5 minutes. Remember that you cannot use endrophonium because the duration of action is just short, okay? So within 30 seconds to 5 minutes, it could reverse muscle weakness, but after that, the effect wanes off. So you don't want to take the medication every 5 minutes. So it's only used for testing purposes. Okay, so neuro exam, well, reflexes and balance are examined, and then electromyography. Okay, so which tests could actually be done in both Guillain-Barré and myasthenia gravis? Electromyography. Which test is specific for myasthenia gravis? Endrophonium test or your tensilon test. Okay, so the medications given to your patients with myasthenia gravis includes your pyridostigmine or neostigmine. Okay, which reverses muscle weakness, your corticosteroids, immunosuppressants like azathioprine or cyclosporine, which would actually, which are given to the patient because myasthenia gravis is believed to be autoimmune in nature. And like in Guillain-Barré syndrome, your IV immunoglobulin therapy, plasmapheresis, and since the thymus gland is implicated in the autoimmune reaction to myasthenia gravis, surgical removal of the thymus gland through thymectomy is usually done. Okay, now let's have our what if mentality again. What if? Okay, the question is about complications. In both conditions, they will have respiratory difficulty. So definitely the priority will be airway. Okay, so since GBS and MG lead to difficulty breathing, the priority is to ensure a patent airway. Don't forget that. And in its severe form, Guillain-Barré syndrome is a medical emergency. It's a medical emergency. Remember, the use of eye patch may help improve double vision, specifically patients with MG. Okay, so let's try answering a sample question. Here we go. Which of the following nursing diagnosis is the priority for, you have here 2 clients who are both with muscle weakness of the arms and legs. Okay, so arms and legs are affected. So think about GBS and myasthenia. difficulty chewing, so GBS and myasthenia, and swallowing, GBS and myasthenia, double vision, yes, GBS and myasthenia, with the other one having an additional complaint of ptosis. Ptosis is specific for myasthenia gravis. Therefore, your priority would be airway, ineffective breathing pattern, because the muscle weakness affects the muscles for breathing. Okay, remember your ABC: airway, breathing, circulation. Now, what if a question would deal with, take note of this, this is a little difficult and challenging if you are left on your own studying this concept. What if, okay, the question would deal with the complications of myasthenia gravis, specifically myasthenic crisis and cholinergic crisis. Okay, now let me tell you about this funny thing. Whether a patient has myasthenic crisis or cholinergic crisis, the main problem would be muscle weakness. So how would I know, how would you know as a nurse that the muscle weakness is associated with myasthenic crisis or associated with cholinergic crisis? We do a test, okay? First, we have to identify what's the cause. If there's too little medication or inadequate medication, then that resulted to muscle weakness, then that's myasthenic crisis. If there's too much medication, remember, too much of the pyridostigmine, your cholinesterase inhibitors, okay, your pyridostigmine, neostigmine, too much of those drugs, the common adverse effect would be respiratory paralysis, okay, manifested as muscle weakness. So the adverse effect of too much medication, still muscle weakness. Here, the effect of little medication is muscle weakness. The adverse effect of too much medication is muscle weakness. Once again, how do we differentiate? Okay, when the muscle weakness comes with labored breathing and dysphagia, think myasthenic crisis. When the muscle weakness comes with slow or irregular heartbeat, heavy sweating, nausea, vomiting, and diarrhea, think cholinergic crisis. Again, muscle weakness with dysphagia, myasthenic crisis. That's the patient missed the medication. Muscle weakness with slow or irregular heart rate or bradycardia or heavy sweating, that's cholinergic crisis. You've given too much medication to the patient, okay? So, to validate whether this is myasthenic crisis or cholinergic crisis, administer endrophonium hydrochloride. What did I tell you a while back? Endrophonium hydrochloride is a short-acting medication. So since you have too little medication in myasthenic crisis, when you administer endrophonium, it will reverse muscle weakness. So what happens? If you administer endrophonium, you have increased muscle strength, that's myasthenic crisis. Okay? However, if you administer endrophonium to a client with muscle weakness because of cholinergic crisis, remember, cholinergic crisis is too much medication, and endrophonium is a medication. It will add on the effect of the excessive medication. So in essence, if you administer endrophonium and the muscle weakness is worsened, in other words, there's increased muscle weakness, then you have cholinergic crisis. Once again, endrophonium that relieves muscle weakness or increases muscle strength, myasthenic crisis. Endrophonium that worsens or increases muscle weakness, cholinergic crisis. So it's like this. Patient comes in with muscle weakness, you give endrophonium, okay? The muscle weakness goes away. So that's myasthenic crisis. How about if the patient has muscle weakness, you give endrophonium. The more that the patient has become weaker, and that's cholinergic crisis. Clear? Okay, good. So once again, treatment for myasthenic crisis, your immunoglobulin, intubation plus mechanical ventilation. Now for cholinergic crisis, you have to administer the antidote, okay, of your medications. And the antidote would be your atropine sulfate. It will reverse the effects of your neostigmine and pyridostigmine and prepare the patient for mechanical ventilation. Okay, now there are certain drugs that may worsen myasthenia gravis. That's a little challenging, I know. Okay, so these are your aminoglycosides, penicillamine. Now penicillamine is used in patients with Wilson's disease to promote excretion of excess copper. It's also used to promote excretion of excess lead in lead poisoning. Lidocaine and your magnesium sulfate. Okay, whew. comparing and contrasting. It's my forte. I like it. So please bear with me, guys. I know this kind of difficult now, especially those who are overseas. I know the night is no longer young, so please bear with me, okay? I'd like to share you this because I want you to succeed on your test. Okay, this time, let's differentiate multiple sclerosis from amyotrophic lateral sclerosis. Okay. So let me just welcome back some of our friends. Okay, so what are usually the common areas that we need to focus on? Okay, so take note, in multiple sclerosis, okay, the central nervous system is affected. Okay, so when you talk of the central nervous system, it's the brain and the spinal cord. There's usually demyelination or destruction of the myelin sheath, and this could be associated with autoimmune reaction. Now, because of that, there's weakness or numbness in the extremities. And then because, take note, the brain and the spinal cord are affected, there's gonna be incoordination, tremors, and unsteady gait. Eventually, it also affects your optic nerve. So in multiple sclerosis, blindness could result. Initially, they will need corrective glasses for diplopia, but eventually they develop blindness. And then they have what we call your Lermite sign, electric shock sensation, specifically on the neck when they bend their neck down forwards, okay? And then they have double vision, slurred speech, impaired sexual bowel and bladder function, like in your patients with Guillain-Barré syndrome. The difference is the impairment in sexual function occurs in multiple sclerosis, whereas in Guillain-Barré, you just have an impairment of bowel and bladder function, okay? Let's move on. In your amyotrophic lateral sclerosis, also the central nervous system is affected, but some cases of ALS are inherited through a pattern known as autosomal dominant, which simply means both male and female offspring could develop it, okay? And the characteristics, you have weakness or numbness in the extremities, described as clumsiness, almost similar to multiple sclerosis. What differentiates ALS is that there's twitching of the arms, shoulders, and tongue. And take note of this, inappropriate crying. So there's gonna be mood swings, laughing, and yawning. So mood swings is more prominent in patients with ALS than in patients with multiple sclerosis, okay? Then you have cognitive and behavioral change, okay? Now, common manifestation, okay, again, between ALS and MS, slurred speech occurs in both. Okay, so let's process. In general, there is no pain in ALS in its early stages, okay? In ALS, bladder control and the senses are not affected. So in multiple sclerosis, bowel and bladder control are affected, just like in patients with Guillain-Barré, but in ALS, bladder control and the senses are not affected, okay? Women who are post-menopause and who smoke are at risk for ALS. And in the early stage of ALS, there's a slurred speech, so the RN should facilitate communication with the use of technologies. Take note, this is a priority for these types of patients, okay? So once again, let's compare. For the diagnostic test, for multiple sclerosis, you have lumbar puncture. MRI would usually be needed. Your MRI is necessary to identify the areas of demyelination, okay? Now, your evoked potential test, okay, measures the time the brain responds to sensory stimulation. So it's a painless procedure, it's non-invasive. It usually takes around 30 to 45 minutes. You can tell the patient about those information. Now for multiple sclerosis, once again, there's no cure. Plasmapheresis is done. Corticosteroids are administered. Now muscle relaxants like Lioresal are administered to patient to decrease rigidity, and of course, administration of vitamin D supplements. For ALS, just like your multiple sclerosis, lumbar puncture and MRI are done, plus your electromyography and muscle biopsy, okay? EMG, just like in patients with Guillain-Barré and myasthenia gravis, okay? So, like multiple sclerosis, there's no cure. However, there are medications that would increase the life expectancy of patients with ALS, like Riluzone and Edaravone, that would help reduce the progression of symptoms. Okay, so let's try answering a sample question. Which of the following manifestation occurs in Guillain-Barré myasthenia gravis, multiple sclerosis, and amyotrophic lateral sclerosis. This is what is funny here, class. Okay. Ptosis, okay, occurs in clients with myasthenia gravis. Inappropriate crying and yawning in clients only with amyotrophic lateral sclerosis. Okay, you're looking for a symptom that occurs in all. Double vision occurs in patients with myasthenia gravis, Guillain-Barré syndrome, and multiple sclerosis. Okay, however, it is not that prominent in patients with ALS. So the one single manifestation that's prominent in most of these conditions, in all of these conditions rather, would be your muscle weakness. That leads to respiratory depression. Therefore, your priority should be airway. Okay. So test taking strategy or test taking key, go slow. Remember, sometimes too much excitement can kill the dream. Okay, so when I say go slow, how many minutes per question would be appropriate? Since on the NCLEX, the run out of time rule no longer applies. Spend around 10 to 15 minutes per question so that you'd be able to analyze it properly. Okay, so this time let's compare Alzheimer's disease and Pick's disease. My God, this is getting exciting. Okay, your Alzheimer's disease is actually due to the presence of your amyloid plaques and neurofibrillary tangles, which destroys the neurons that secretes your acetylcholine. So remember that acetylcholine is the neurotransmitter that helps preserve memory. So if you destroy that because of the presence of the amyloid plaques and neurofibrillary tangles, patient will have poor memory. Okay, so the patient with Alzheimer's disease would initially manifest personality changes and then perseveration. They repeatedly verbalize phrases with no meaning at all. Then they have delusions, and then eventually they have aphasia. Okay, so medications that prevents the destruction of acetylcholine would usually be given to the patient. Okay, your cholinesterase inhibitors, Aricept, donepezil, remember the code AGE, galantamine, Orazidine, and your Exelon or Rivastigmine. So AGE, Aricept, galantamine, Exelon for clients with Alzheimer's disease. Okay. Ginkgo biloba is an herbal supplement that thins the blood. It helps improve the memory of clients with Alzheimer's disease by increasing circulation in the brain. Okay, and then you can also give vitamin E to patients with Alzheimer's. Now take note, for patients with Alzheimer's disease who are taking blood thinners, okay, you will have to assess, okay? Why? Because your blood thinners, your ginkgo biloba may worsen bleeding in patients who are taking blood thinners, okay? In Pick's disease, okay, there's the presence of a protein called tau protein, okay, which forms your Pick bodies, okay? And these Pick bodies, when it accumulates, leads to the following changes, okay? Personality changes, impairment in the functioning of the frontal lobe as well as the temporal lobe, so impaired planning, judgment, executive function. Language difficulties like aphasia could actually result. And here you don't have specific treatment, but you can administer antidepressants and antipsychotics to decrease psychiatric symptoms. Now, question. Is there a clinical way of differentiating whether the patient is having Alzheimer's or Pick's disease? At a glance, physically, sometimes the personality changes overlap, that it's very difficult to say whether the patient's having Alzheimer's or Pick's disease. But what matters the most is that when a patient has personality changes, you can treat it as a form of dementia, and therefore your priority should be reorientation and promoting safety, okay? So the diagnostic test would be MRI, CT scan, or PET scan. Okay, remember, advancing age is the best known risk factor for Alzheimer's disease. Let's use this functional concept later on. Pick's disease occur at an earlier age than Alzheimer's. Usually the onset of Pick's disease is around 40 to 60 years of age, and that of Alzheimer's above 60. Although some studies have shown that Alzheimer's could actually occur as early as 40 to 50 years of age, okay? So let's try answering a sample question. Which of the following clients is most at risk for Alzheimer's disease? Now, what did we say? Advancing age. Look at this class. 25-year-old who got hit with a tennis ball on the head? No. 42-year-old postmenopausal female? No. Okay. 69-year-old client who failed to graduate from high school due to poverty? Advancing age. 50-year-old who occasionally forget to lock her bedroom door? Well, this is acceptable, not necessarily indicative of dementia, but there has been some evidence to suggest that low educational attainment is a risk factor for Alzheimer's disease. So best answer is number 3. Okay, so in a patient with dementia, priority intervention involves frequent reorientation. Okay, don't forget that. Here's a sample question. Let's use what we learned. A 65-year-old patient who frequently asks a nurse, "Where is the bathroom?" is found walking naked in the day room. When the nurse asked the client where she's going, she answered, "I feel dirty. Oh my God, I need to take a bath." The nurse knows that the client had already an early morning bath. Which intervention is appropriate for the nurse to implement? Okay, you know that the patient had already an early morning bath, patient feels dirty, the patient's walking naked. Those are the facts. Let's use the syndromic approach to functional concept analysis, okay? Map the story in your mind. Are you going to escort back the client to her room and say, "You are not dirty"? Or 2, tell the client, "You had your bath early today, but if you need to clean up, let me bring you to the bathroom." 3, cover the client with a bath towel, bring her to the bathroom. And 4, hold the client's hand and say, "I am your nurse, and I want you to follow our unit rules. Please dress up." Which one adheres to the principle of reorientation? That's option number 2. Tell the client, "You had your bath earlier today, but if you need to clean up, let me bring you to the bathroom." Excellent. Okay. Now, I'd like to highlight some reminders on isolation precautions. At our YouTube channel, Gapos Mentors, I have a full discussion, parts 1 and 2 of isolation precautions and standard precautions separately. Please visit the channel and browse through our collection of videos, and one of it would be isolation precautions. This is QuickFix. I'm just going to highlight what those who are taking the test for the month of October need to know. Okay, so clients with AIDS should be placed on standard precautions. Patients with botulism, standard precautions. Chickenpox, airborne plus contact plus standard. These are now according to the new guidelines of CDC. Legionnaire's disease, standard precautions. Bubonic plague, standard precautions. Shigellosis, standard precautions. But if you have a patient below 2 years old or a patient who's diapered, implement contact precautions, okay? Having that in mind, let's use this to answer a question. Let's apply what we learned. Which of the following patients are being cared for with the appropriate type of isolation precautions? A 2-year-old with bubonic plague on droplet precautions? No. Said a while back that contact should be indicated if you have below 2 years old, but chances are for adults, standard. 31-year-old varicella airborne? Yes, airborne precautions indicated for MTVS, measles, tuberculosis, varicella, and SARS. 45-year-old with AIDS on standard precautions? That's correct. 18-year-old with shigellosis on droplet precautions? No, shigellosis should be placed on standard precautions. Okay. I'm sorry, bubonic plague should be on, standard precautions. Okay, it is actually the patient on shigellosis who is diapered or below 2 years old that should be placed on, okay, contact precautions. Here, no, shigellosis, standard. For those below 2 years old, they're having diarrhea, that's when you place them on contact precautions. Sorry. 5, 10-year-old with botulism on standard precautions? Yes. And 6, a 42-year-old with Legionnaire's disease on airborne? No, Legionnaire's disease should be standard. Airborne precautions applicable only to MTVS, measles, tuberculosis, varicella, and SARS. So this one is an X. Okay, way to go. So let me have a shout out this time from a young gentleman from Quezon City who passed the NCLEX RN last September 9 for the State Board of New York. Okay, his name, Kenneth Bayoginia. Congratulations, Kenneth. Okay, said, "Thanks, sir, God bless." Okay, and he actually posted this on his Facebook, "Ask and it will be given to you, seek and you will find, knock knock at our class and the door will be open to you. Thanks, Papa God. Thank you to Our Lady of Manawag, St. Jude, Santo Niño, St. Joseph Cupertino, St. Clair. Thank you to all those who prayed for me. Okay. There's a lot of stress in the review, but it's worth it. She said thank you to her fiancé Bads, okay, for pushing him every time, and the rest of his loved ones. Okay, Kenneth Bayuginya, BSN, RN, CNN, USRN, to God be the glory. And everybody say, I'm next, I believe. Okay. Okay, this is his appointment data, and that goes the status. It shows pass. Okay, September 9, 2020. Excellent. So this is actually the end of session 5. It's a little faster this time. Okay, that's me again. I love to show that graduation pic, okay, with my classmates in the US. Okay, so always remember, this is Mentor Ray saying a functional concept a day keeps your NCLEX RN fears away. If you love this video, please don't forget to subscribe and hit the like and bell buttons. Gapos Mentors, visit our YouTube channel. Finish watching the ads, please, so we could actually send some nursing scholars to take their NCLEX and apply.